Waveney Clinical Commissioning Group. My name is Dr. Anoop Desi, and I'll be chairing the meeting today. This meeting is not being broadcast live, but it is being recorded and will be available to be watched from the CCG website after the meeting. Members of the public have been invited to join the meeting and may be watching it live. If there are members of the public watching, can they turn off their microphones and their cameras, please, during the meeting? There will be an opportunity for members of the public to ask questions about any of the items on the agenda for clarification, or if they are uncertain of anything that is being discussed within the meeting. If they want to make a comment or ask a question, can they raise their hands using the slot on the screen, and I'll try and bring them into the meeting. Members of the public can also raise questions by email during the meeting by emailing nwccg.communications@nhs.net. If the question relates to an agenda item, then this will be read out at the end of the meeting, and the governing body will either answer the question or defer the answer, in which case a response will be prepared in writing to the requester within 7 days of the meeting, and it will also be published on the website. I remind you that the governing body meeting is a meeting of the CCG which is held in public, but it's not a public meeting, so questions not relating to the agenda item will be answered and displayed, but will not on the website, but will not be read out during the meeting. Finally, as the meeting is being recorded and will be in the public domain, members of the public are asked to refrain from sharing any personal information or any information that might relate to a third person when they raise questions or request clarification regarding agenda items. Okay, so hopefully you've got your agendas in front of you, and we'll move on to item 2. I haven't got any actions to report that have been taken since our last meeting. We have got quite a long agenda, and I'm going to try and manage it as well as I can. So can I please ask you to assume on the whole that that board members have read the papers and be clear about what the salient items that you want discussion or debate on, and I may prompt you to keep to time as well, but can you try and do that yourselves as well? So item 3 is apologies. Jane, have we had any apologies?
Sorry, apologies were received from Mark Jeffries, Anna Morgan and Mark Burgess.
Okay, thank you. Item 4 is declarations of interest. Firstly, a reminder that the register should be kept up to date. It's available on the CCG website, and if there are items on the agenda which that you may be conflicted on, can you either tell me now or certainly when we're at that agenda item, if you can make me aware. Rob.
Yes, thank you, Chair. Just a reminder, family member is part of the national vaccination programme, and we have an update on vaccination programme at item 9.
Okay, thank you. And I ought to then declare an interest as well that my wife is a vaccinator, and that item is on the agenda. Thank you. Item 5 is to approve the minutes of the last meeting, which was on the 27th of July. I'll take it as a whole. Are there any items of accuracy or points of accuracy on the minutes of that meeting in July? No, so I'll approve them as being accurate. And are there any matters arising from those minutes, which we're not covering on the agenda? No. Okay. Thank you. So next is item 6, the action log. Many of those items are completed or actioned. There were a couple there which have got explanations on them. Kath, particularly there's a couple that relate to items with your name next to them, 10 and 11, I'm thinking particularly. I mean, there's an explanation there of where we are, but are there any anything you want to say on those items?
No, thank you, unless there are any specific points that required clarification.
Okay, no, I mean, it seems pretty straightforward to be honest, but I just want to check. Okay, great, thank you. Well, we'll move 4 minutes early. We'll move to item 7, and Melanie, I'll ask you to talk to your report.
Thank you very much, Anoop, and good afternoon, everyone. I won't mention many of the topics in my report as they're covered by major items later on the agenda, but I did want to just highlight a number of things. Kath Byford, our Chief Nurse, is going to talk about the Safeguarding Adult Review into the deaths of Joanna, John and Ben King. The Safeguarding Adult Review was published on the 9th of September, so since the governing body last met. I wanted to just add my comments that this has been, as you would expect, one of the most difficult things that the CCG has ever faced, has ever dealt with, and for me personally, and for a number of colleagues. We are taking the learning from the deaths extremely seriously, and continue to focus on it with staff who have been affected from across the whole organisation, in fact, not just the teams who are directly involved in those cases. And Kath will say more about that later. I wanted to also just touch on another issue, which again has been very challenging since the governing body last met, and has supposed escalated over the course of the summer, which is the abuse that health and care staff are now receiving from members of the public. And I wanted to just call out that abuse to NHS staff or care staff is totally unacceptable. It starts off as anger, gets cross, escalates into shouting, and then we have seen some tragic incidents of physical abuse and vandalism. And the impact that this is having on our primary care services and all of our healthcare services and care sector is significant. We're getting great support from Norfolk Police, but it really shouldn't come to that when people are trying their very best and also recognising and understanding the frustration and difficulties that people are living with. So I'm very sad that continues, and would just ask for everybody's support to our staff and for the public's understanding as much as possible. On a brighter note, Norfolk and Waveney has been selected as one of 4 systems to take part in a major piece of research by Oxford University, and this has been commissioned by the Department of Health and Social Care. It will be a year-long piece of research that will give us great information about how we're making decisions and the benefits of us coming together as an integrated care system. Hasn't quite started yet, but I expect in coming weeks that will happen, and I expect there'll be huge benefit from having such a high quality group of researchers working with us. So it's really brilliant. And again, on the topic of national recognition, we've again been shortlisted for so many different awards. Many of them are down to the fabulous COVID Protect and Protect Now intervention, focuses on the most vulnerable people in Norfolk and Waveney. It's been a great example of clinical leadership, but also of innovation. So true innovation and creativity by clinicians and managers coming together and being given the space to innovate and look at the results that it's had. So I'm delighted that we've had that recognition, but I'm also delighted to learn about the impact those tools and techniques have had and the potential for more. So thank you, Anoop. I'm very happy to take any questions on any other aspect of my report.
Okay, thanks very much, Melanie, for the report and your commentary on it. Are there any questions people want to ask, any comments they want to make? Okay, thank you. So we'll move to item 8, which Melanie referenced. One of the most significant things that's happened, that the CCG's had to deal with and face, which is the Norfolk Safeguarding Adult Review, and I'll hand over to Kath to introduce that item.
Thank you, Chair. Hello, my name is Kath Byford. I'm the Chief Nurse of the Norfolk and Waveney CCG, as said, I'll be talking to the item on the Safeguarding Adult Review that was published on the 9th of September, and that was about the deaths of 3 residents, 3 young adults, Joanna, John and Ben, who were all inpatients at the Giselle Corston Park Independent Hospital for people with learning disabilities, which was in North Norfolk. It's now closed as a result of the CQC removing the registration, but clearly there were significant tragedies and compromising of human rights of the 3 individuals that were investigated, along with other feedback from other patients and their families. Firstly, I'd like to say that Norfolk and Waveney CCG fully accepts the findings of the Safeguarding Adult Review, and we do recognise that we didn't get this right, and our commissioning of services and oversight of Ben's care, who Ben was a Norfolk resident, was not good enough for him and his family. The report sets out a number of different aspects to our response in relation to both the publication of the Safeguarding Adult Review, but our own awareness of the improvements and changes that need to be made. These need, some of which are in partnership with system partners, including our colleagues in both Norfolk and Suffolk County Council, but also providers across the system. So there are a number, in section 2 of the paper, you'll see quite a number of changes to our approach to commissioning of services for people with learning disabilities and autistic people. And just a couple of points to make, one of which is the commitment to pursue a pool budget with adult social care within Norfolk County Council, and the way in which we, because currently we have a joint approach to commissioning of services for people with learning disabilities and autism, but a full review of that to ensure that there is the capacity and leadership within that team to be able to work at the ambition and pace that we have. Section 3 of the paper picks up on the enhanced oversight of the patients and people that we are responsible for, and very much it will be, and what is already started, but focus on the lived experience of the individuals, not just the patients themselves, but also their families, and that will be the driving force for everything that we're doing. So we have already put in place, but this is a commitment to ensure the enhanced approach to reviewing how we track our patients, maintain direct oversight of care and treatment, have greater rigour, pace and challenge within our system for discharge planning of patients at a much earlier stage of their admission to inpatient settings, and a real focus on the physical health and quality of care being delivered to patients who are within inpatient settings. We're also committed to working with our citizens, so in conjunction with our colleagues in our comms and engagement team, we are planning an active engagement process with people with learning disabilities, autistic people, their families, but also the wider population. The needs of that population is not being met effectively, and the feedback from those engagement sessions will actively inform both our health and care commissioning and purchasing of services for our population. In terms of oversight of providers, section 5, sets out the rigorous approach to quality monitoring, enhanced by a number of measures, which includes reviewing every single person in an inpatient setting every 8 weeks, and that will be a face-to-face review. Enhanced and improved quality improvement visits, and including in that is bringing external clinicians and expert by experience or people with lived experience to contribute to these visits. Really in relation to looking at the continuous review of harm of patients as a result of their health and care provision, ensuring that we have a much more active eye for the risk of harm and enable to intervene at an appropriate stage. In terms of the governance, governance and system oversight of health and care for people with learning disabilities and autistic people has not been sufficient or effective within the Norfolk and Waveney system. We are currently discussing about how this will be significantly enhanced and how the Learning Disability and Autism Programme will report into the Integrated Care Board. There will be an improvement programme which sets out all of the actions associated with the recommendations within the Safeguarding Adult Review, along with additional actions for improvement that we are committed to putting in place. And the Learning Disability and Autism Programme Board, which was previously known as the Transforming Care Board, has already been improved with reinvigorated leadership by both myself and James Bullion, the Exec Director of Adult Services for Norfolk County Council, and I'm personally working with Suffolk County Council and colleagues in SNE to ensure that the Waveney population are equally able to benefit from a much more collaborative approach. So in conclusion, the tragic deaths of Joanna, John and Ben that resulted from inadequate care provision and oversight is going to be it will drive improvements to how we collectively commission and oversee health and care services. And the CCG is committed to preventing another person or their family experiencing a physical or emotional harm as a result of services that are ineffective or inadequate. And we will achieve this by working with system partners and changing how we work in avoiding admissions, improving the oversight of patients and seeking innovation in our practice and commissioning. So I'd like to stop there, Chair, and very happy to answer any questions from governing body. Thank you.
Okay, thank you very much, Kath. So we'll take questions. So Tracy.
Yes, thank you, Kath, for outlining all of the plans going forwards. And I know it's been a very kind of harrowing and difficult time for all concerned, particularly the families, and really sad as well. I think for me, I'd like to hear a little bit more about how we are. I think we know that those people that have a learning disability, autism, struggle with communication, struggle to express their needs, and we do know more adversely affected with suffering from health inequalities. So I think sort of families, carers, friends are key often in supporting those individuals, and just how in kind of the care that we provide, how we're engaging with the family, the carers in that care provision, and kind of listening to their concerns. So kind of what are our approaches to doing that going forwards? We talked about the engagement that you outlined and with communities generally, but just thinking about the actual kind of ongoing care engagement with those families, and actually addressing those wider inequalities that those people with a learning disability and autism do have in accessing healthcare and health outcomes as well.
Thank you, Tracy. So in terms of the wider engagement with people with learning disabilities, autistic people and families and the wider population, that will be a programme that we will develop in partnership with people who with lived experience and experts by experience, sorry. But I think importantly, it will be how the learning addresses how we directly liaise, engage with patients and their families of people that we are sourcing and providing care or inpatient provision for. And one of the lessons learned from the Safeguarding Adult Review is Ben, who was our patient, we weren't actively communicating with his mum, and his mum was the person that knew Ben the most you know, in his whole life. And we relied upon, we thought we were doing the right thing, but we relied upon another colleague across the social care system to be that point of contact. And that really lost the opportunity to hear from Mum and to hear about her observations, her worries and her concerns. So that was a real learning point, and recognition of one of those areas where I said we didn't do a good enough job. And one of our commitments is to make sure that that does not happen again. So every one of our patients that we are overseeing the commission of services care for, or inpatient setting for, my nurses in my team will directly communicate with those family members to listen, actively seek out the views and the experiences of the care that's being received, in order to never let the lost opportunity to hear the voice of Ben through his mum, and make sure that never happens again. In terms of then the wider, we know there is significant health inequalities, and both the national and local leader programme, which is the learning from the deaths of people with learning disabilities, demonstrates approximately 20-year mortality gap, which means that people with a learning disability tend to die 20 years on average sooner than people without a learning disability. So we recognise actually within the concept of health inequalities that people with learning disabilities are probably that group that are the most exposed to those health inequalities. Now, every person with a learning disability should be able to access an annual health check, which is undertaken by their local GP, which is a focused, dedicated session annual health check to be able to explore in depth the health needs of the individual, make sure that they're not missing out on things such as even cancer screening programs, make sure their teeth are being well looked after, for example. And we know that that was affected through the pandemic, and because there was less face-to-face sessions, but we are really quite actively improving the annual health check uptake. And there is a pilot within the Norwich system that's really doing some dedicated focused work on improving the uptake, both numbers of people being checked and the quality of those checks. And we will take that learning with a view of rolling that out across the whole of Norfolk and Waveney once we understand the successes and opportunities to improve further. Thank you, Tracy.
No, thank you. That's really helpful. Thank you.
Okay, thank you, Tracy and Kath. Melanie?
Thank you. I just wanted to add a few more reflections really on the back of Tracy's question. For me, I think this is more general, raising awareness and understanding of some of the challenges and some of the opportunities and changes that can be made for people with learning disability and autistic people as well throughout the whole of the organisation. So yesterday I met with all of our senior leaders across the whole of the CCG and asked them, whatever their role is, think about what difference you can make for people with learning disabilities and or autistic people, whether you're in finance, whether you're in primary care, whether you're in nursing, whatever your role is, think about how you can make a difference. We are, as Kath said, also recruiting a number of people who have specialist detailed knowledge. I'm very grateful we now have a number of specialist learning disability nurses, either in direct in the quality and care team, who will have more direct patient contact, but also amongst commissioning staff as well. That's very important. And I think I would really like to find opportunities working with the voluntary sector in Norfolk and Waveney, particularly for us to include people with learning disabilities or autistic people as role models. And I've been just hooked to the CBeebies website recently, watching the wonderful George Webster, who's 20 years old with Down syndrome, as a guest presenter. And I would love to find opportunities for us to have that really positive role model in what we're doing in Norfolk and Waveney.
Thanks very much for that, Melanie. Arden.
agreeing with Melanie. Historically, I think we've been guilty of not including provision for people experiencing neurodevelopmental disorders, learning disabilities, in all of our services. So a commitment from the mental health team is that all new pathways of care will include provision for people with learning disabilities and autism, with additional specialist pathways when needed. But our absolute commitment is for people with NDD to be included as business as usual in all of our pathways of care, both for adults and children and young people.
Thank you. Kathy?
Thank you, and thanks, Kath, for a comprehensive paper on a really difficult subject. And as chair of the Quality and Performance Committee, I agree that our oversight of this case was insufficient and we need to do better in the future. So thank you for that. I guess part of my question has been answered really, because it's a far-reaching action plan. And sometimes when you've got a big action plan and lots of ambitious targets, you can lose sight of the people that you're trying to serve. So I think quite a lot of that has been answered. But I suppose my question is you've outlined a number of things which will enhance governance and bring it to a more system level. But I still wonder whether we need clarification on how we will assure the governing body that we're delivering on the action plan. And secondly, it's got very ambitious timescales in it. And I just wondered whether you think there are risks associated with delivering that action plan. Thank you.
Thank you, Kathy. So the time scales that I've set out in this paper were deliberately ambitious in order to really reinforce my personal commitment, but our as a CCG commitment to working on this at a pace and as a priority. There will, though, be a more detailed action plan, partly to respond directly to the recommendations from the Safeguarding Adult Review, but as I said earlier, a more granular action plan in relation to those other areas which we know that we will we do require improvements. Some of those actions will be dependent on working in partnership with colleagues outside of the CCG. But again, my approach was to set the pace and ambition to do this quickly, but properly. What I would suggest is that through the Quality and Performance Committee, that action plan is overseen, including specific milestones and deadlines, and where there is a need to change those deadlines or milestones, that will be agreed through the Quality and Performance Committee, so that then the Quality and Performance Committee, through yourself, can assure the governing body of progress or changes to the milestones and the reasons why.
Thank you.
Okay, thank you. Any further questions or comments? Okay. Well, we're asked to note that the CCG fully accepts the findings of the report, as Kath has said, that we didn't get it right, and that we will play a very central role in making sure that we learn the lessons and actually improve services going forward. So we're asked to endorse a commitment to transformation of services that plan, commission and deliver care for people with learning disabilities and autistic people throughout Norfolk and Waveney. And in particular, I think I would also like to add that it's really important that as we transition to new organisations, that we make sure that this piece of work, which is crucial, that it's not in any way diminished by organisational change. So can I ask you to endorse that approach? Okay, thank you. Okay, so we'll move then to item 10, which is, no, item 9, apologies, which is an update on the COVID vaccination and flu planning. So Howard, you're going to start the discussion on that.
Yes, thank you, Chair. So the paper is here for noting and comment. I will take it as read and just provide some further updates on progress. I think we always need to start this programme just by saying well done to everybody across the system for what has been a tremendous campaign. We can't, I don't think, say that enough, frankly. But so first of all, I'm pleased to report that the Phase 3 booster campaign was approved to commence and has actually started from last week. We've got some early numbers, so we've actually delivered already 5,000 COVID boosters and some 17,000 flu vaccinations. Those numbers will, of course, ramp up considerably over the coming weeks, particularly up in the run-up to December. I'm also pleased to say that the risk that we identified in Part 6 of the report relating to primary care involvement, we believe has now been resolved with support from our regional colleagues. We're expecting the majority of our primary care networks to support this programme, and we are incredibly grateful that they are doing so, given how effective primary care has been in the first 2 phases of the vaccination programme, in particular with in relation to vaccinating our more vulnerable population, so in particular care homes and housebounds. Just also a quick update on the numbers on community pharmacies. So this is now firming up to be 19 approved pharmacies. 12 have already commenced boosters, and the rest are hopefully going to be starting within the next week or so, and we have another 4 awaiting approval, so likely to be a maximum of 23 community pharmacies in total. And I guess the final point really is, you'll of course all be aware of the recent issues with the logistics chain in the UK. The current issue with fuel at this point does not appear to be impacting the programme. But of course, you'd expect that we'll be keeping a very close eye on this, and also the other issue related to delivery of flu vaccinations also appears currently to have resolved itself. But again, we'll be keeping a very close eye on that one. So I'm happy to take any questions, and once again, thank you so much to everyone who has so actively supported this work over the last 10 months. Thank you.
Okay, thank you, Howard. So any questions for Howard? Rob?
Yep, thanks for the report, Howard. Very clear, thank you. And I'd endorse your opening and closing comments about our appreciation for everything that everybody is doing to make this a success. I had 2 questions, Howard. Firstly, on hard to reach groups, we had a very good update earlier on in the year about the work that we were doing in relation to hard to reach groups. So I wondered whether you'd like to provide any update on that. And then secondly, in the report, there's a reference to problems with the flu vaccine supply. And I wondered whether that's a local problem or whether it's a national problem. Thank you.
Thank you, Rob. So I'll take them in reverse order. So the issue with the flu vaccine supply that you mentioned, Seqirus, was actually a national issue. We've been advised that that's largely because that vaccine was coming from abroad, basically, so coming from Europe into the UK. We're not expecting the same issue with the COVID vaccine because that's all currently in the UK, notwithstanding all the issues that are very well recorded now about the logistics chain in the UK. But in terms of the hard to reach groups, I think it's a good point, Rob, and happy perhaps at the next governing body to give a much more detailed update on the incredible amount of work that's been happening in that space in terms of the how we're trying to reach our hard to reach groups. And I'll invite Tracy in a second just to comment a bit further on that. But I think at the minute, it's probably fair to say that so the gap between our least and most deprived population reduced from a sort of high of about 16%. So 16% higher uptake amongst our least deprived population versus our most deprived. That's reduced down to about 14% approximately, and has remained stubbornly pretty much at that level. So we really are into kind of marginal incremental gains, which in terms of grand percentages on the population of 1 million, of course, don't necessarily impact on the percentages, but we really are delving down into very small numbers, really in quite specific areas. The areas that we're most concerned about are and remain Yarmouth Parade, parts of Kings Lynn North and South, Thetford North, and also parts of Norwich. And there's been work, including the roving bus, has been visiting all of those areas and continues to do so. Tracy mentioned the worry bus, which is a new innovation that we've developed over the last 4 weeks to try and address people's concern. Paul mentioned as part of his presentation on the AGM the huge amount of work that's happened around comms just to try and reduce some of those concerns and worries that people might have. And we've supported all of that with lots and lots of offers around walk-in facilities to make access as easy as it possibly can be through sites. And I need to mention again the really great collaborative work that we've had with Norfolk County Council in developing that website for the walk-ins, which also includes Waveney patients, I hasten to add. And they've now developed that to include, I think, about 6 different languages. So, and it's really clear and easy to read. So, Tracy, I don't know if there's anything else you wanted to add to that.
Yeah, I'm happy to kind of focus in the areas in respect of our kind of underserved communities. So our more health inclusion groups, which will be our homeless, our gypsy road travellers, and people that are sex working, people on released from prison, forced migrants. So actively last year we had a really good flu campaign working with our voluntary community sector organisations and our district council colleagues, all of whom we are working with very closely in respect of vaccines inequalities generally. And we are planning a series of kind of roving events using the voluntary Norfolk SOS bus to go out to communities and to hopefully provide both the COVID booster vaccination and the flu vaccination. And we're actually planning that with our colleagues in districts, community sector organisations, and working with our public health colleagues very closely. So learning lessons from both our phase 1 and 2 of the COVID vaccination programme and our flu vaccination programme for inclusion health groups last year. So I'm very actively involved in that. I'm very happy to provide an update at a future meeting, as Howard has suggested as well. Hope that's helpful.
Yeah, thank you both. That's really helpful. Thank you.
Okay, thank you. Doris?
I think just building on that, are we confident that we're working off a data set that is actually up to date and reflect the population we have? Because I think there's 2 issues. One is where people have moved back to their where different parts of the country or back to the EU. And similarly, there are patients who are or residents who are not actually registered with GP practices.
I think that's a really excellent point, actually, Doris. So I think that possibly is an issue in some cases, but in terms of the accuracy of the database, I actually think in Norfolk and Waveney we're at the cutting edge of some of this. So some of the data that we've mentioned through, for example, the Protect Now work, we've managed to extract information from GP practice systems to support the vaccine program. So we're actually using very, very up-to-date information to identify people who have not yet had the vaccine and work out how we can target. But that's not to say that there aren't data quality issues within there that perhaps need addressing. But I think in answer to your question, I think fundamentally we are using the most up-to-date data that we possibly can. I don't think there's any more that we can do on that front.
Okay, thank you. Any other questions or comments for Howard? Well, thank you very much, Howard, for that update. I think we're asked to note the progress on that. So, and thanks very much for all the hard work that I know that is very much appreciated. So let's move to item 10, which is to discuss the current issues with waiting times and elective recovery. And I hope that Mark's on the call.
Thank you, Chair. Yes, I am. Thank you, Chair. I'll take the paper as read, but there's been further meetings of the elective recovery board since this paper was written. So I'll also update now governing body members in relation to that. So as governing body members will see, there are challenges across a number of the different elective activity pods in the system, but one very sort of specific problem is in relation to elective day cases and inpatients, which, as you can see from the from the data is the area where, relative to our previous position, we are the furthest behind. In the past couple of weeks, we have decided to step up our efforts in relation to that. So up to this point, we have been managing quite a lot of that piece of work via a work stream which is focused on theatres and day cases and inpatients. But we've changed tack slightly on that, and we've now included 2 additional work streams in the elective care recovery board. So first of all, there's going to be set up an elective recovery group specific to orthopedics. So if we look at our long waiters, just under half of them are due to orthopedics, and it is mainly at the Norfolk and Norwich where those very long waiters for orthopedics sit. So we agreed at the elective recovery board yesterday that there would be a specific group set up for that, and it would be chaired by a medical director in the first instance, but then handing over to a lead consultant, which we think we've identified sort of going on from that. So that should help, you know, the situation in relation to orthopedic recovery. The second area to update governing body members on is in relation to ophthalmology, which is our second largest area of waiting list length. So, you know, for that we have also commenced an eye care tactical group, which meets every 2 weeks on a Friday, and that not only just considers the pathway discussions which many GPs on this group will have been involved in previously, but again, just actually talk physically about, you've got these patients here, you've got these patients there, how can we move them, and so forth. So we will need to keep a very close eye on it, because particularly for those 2 specialties, but that's what we've decided to give some very close focus on in the next few weeks and get some more specific operational actions in relation to. Just in terms of other areas, so the flexible sigmoidoscopy, we are low compared to our baseline levels. We have compared it to other areas, and the other areas don't seem to show, you know, the same discrepancy. And we believe that the reason for that is that we were relatively late in implementing the fecal immunochemical testing in Norfolk and Waveney, and that is certainly the case. It was implemented towards the back end of 2019. So what we'll do is we'll keep an eye on the fit testing numbers to ensure that they are going up. And we've already had one session at a Great Yarmouth clinical exec previously to discuss the below uptake in the Great Yarmouth Waveney area going forward. Finally, just in terms of the aggregate data, for the outpatient transformation work, which is CCG is the lead area on, although relatively speaking we are meeting the targets, there is still a fairly big difference between the 3 hospitals in relation to the use of the modalities. So virtual consultations are much more common in the Norfolk and Norwich than they are at the James Paget and the Queen Elizabeth Hospital. Likewise, the use of patient-initiated follow-up. So we're going to be setting up a series of specialty workshops just to agree STP-wide which things should be implemented in which particular sorts of patients. So in essence, you know, an STP-wide policy on virtual consultations and PIFUs for some of the key clinical areas. So I'll leave it there and ask for governing bodies comment and questions. There's quite a lot of work streams associated with that, so I appreciate that there may be sort of specific areas of detail you may wish to inquire further on. Thank you, Chair.
Thanks, Mark. Tracy?
Yeah, thank you, Mark. That's a really helpful update. You mentioned in your paper some of the analysis that Howard has kind of been leading on with public health colleagues in respect of the inequalities in the waiting list, yeah. And that was discussed, I believe, at the Elective Recovery Board this week. I'm just wondering if kind of the views from the Recovery Board, and I looked at that data as well, and it was absolutely fascinating just to understand that a little bit. How that might impact on kind of any of the plans going forward when the elective board have looked at that kind of, you know, the impact of those inequalities on those elective waiting lists.
Yeah, thank you, Tracy. I think if I commence the the discussion on that and how did you come in if you're still on the line. So I think so. It was quite interesting in the sense that the most deprived areas didn't appear to be overrepresented in long ways, and the most deprived areas did not also appear to be overrepresented in relation to waiting for effectively their first contact. So, so in one sense, that was slightly reassuring. But the other thing the Elective Care Recovery Board did think about is actually for someone who's more deprived, is the impact of actually waiting for an appointment, disproportionately high. So someone who may be, say, a manual labourer, for example, who's, who they may wait at the same time as someone who's perhaps in a non-manual job, but the impact on them would be more severe. So we agreed that we need to do a bit more work to understand that. We had a commitment from our acute colleagues to try to find that information where possible. We don't currently routinely collect it, but they will attempt to get that information. So in relation to community diagnostic hubs, it's been a process that we've had to tread quite carefully in relation to our application, because we also have business cases going in relation to diagnostic assessment centres, which could potentially bring up to £70 million of funding to develop elective diagnostic capacity, but that only goes online in 2024. So what we've put in relation to this year is that we've essentially given a narrative that would be used tactically to sort of place mobile units using the hospitals as hubs in relation to that sort of immediate activity. In the medium to long-term plan, we are currently just doing a sort of a options appraisal in relation to future sites potentially. So based on activity data at the moment, it's possible that there may be 3 additional sites going forward, but we're doing quite a lot of careful analysis to look at that, because for the radiology data, I think the Richards review provides us with a very sort of robust and evidence-based way of trying to project that future activity. But for things that fall outside the scope of the Richards reviews, such as the phlebotomy, just for example, then we more or less have to try to estimate demand based on historical trends, also based on potential changes to clinical pathways and so forth. So that's a bit more of an involved piece of work. So that piece of work is being led by Dr. Erica Dendon, who was previously the National Community Diagnostics lead. So I think we've got a good lead there to lead that piece of work. We're also just in the process of engaging the former National Transformation Lead for Imaging as well, and she was in that post for 4 years and has a good sort of personal connection with Dr. Denton. So so we should get some expertise in the system to help us develop those plans in greater detail. And I think she commenced work this week. So we should be in a position to be a lot more clear in the next 1 to 2 months about what the feasible options are going forward in terms of that particular work programme.
Okay, thanks, Mark.
Okay, I think is it Claire next, then Arden.
Thank you. Again, thank you for your report, Mark, and the additional feedback that you gave, which is again very, very useful for awareness. You mentioned patient-initiated follow-up, which I think is a really interesting concept in healthcare, but relatively new, although I think some specialties perhaps already use it. I guess it's something that may work very well for people who have a good understanding of their condition and feel empowered and feel able to access services when they need it. But what mitigations do we need to consider to ensure that we don't inadvertently drive inequalities and disadvantage the most vulnerable people who may find accessing through that method more challenging than others?
Thanks, Claire. I think that's a very good question, and that question could equally apply to virtual consultations as well. So what we're looking at is that we need to develop ICS-wide SOPs essentially for patient-initiated follow-up and for virtual consultation. So we have sort of asked, the regional team whether or not they have any from other systems or there's a national guide in relation to that, and they haven't been able to locate any for us. So this will be very much for us in our system to agree, those particular sort of safeguards and inclusion criteria, exclusion criteria. And I think when we've discussed it in a group, there are actually two kinds of people in that group that you mentioned. So there's both the patients who aren't suitable for PIFI or virtual consultation by virtue of what they actually have, and then there's another group which is who may be suitable by virtue of what they ever had, but for a reason that's not related to their condition needs sort of standard care essentially. So I think that will be what we need to figure out. We won't be able to cover every specialty immediately, but I think with our workshops in which we plan for late November, we will be able to actually sort of iron out then an agreed position in relation to those particular topics.
Yeah, thank you. Thanks very much, Mark. Really good paper. Couple of thoughts from me. One was around the discussion we had earlier around those vulnerable people in deprived areas who are not waiting as much, and potentially that of course could be related to the fact that they're just not coming forward because they find it more difficult to access for instance, and have been paid by the hour. So I think as a system, we need to be clear that we're making reasonable adjustments for that to happen so that people in those areas can access our services. And my second thought was around the rise in gastroscopies, which shows the highest growth, doesn't it? And perhaps thinking about our open access endoscopy system and whether we can perhaps learn from some of the people coming forward for open access gastroscopy having negative findings, and what the learning might be in terms of feeding that back to primary care around perhaps a more robust workup of those people before we put them forward.
Yes, no, that's a very good question. So historically, we have had sort of differing arrangements for open access endoscopy across the old CCG. So you may be members may be aware that the St James Medical Practice used to have an open access endoscopy sort of facility, and also that also used to be available at the James Paget. So for the time being, what we've stated is that they would each operate a triage model in relation to the acute hospitals at least, and for St James's, their entry on the referral system has been changed so that that's a triage model as well. Although the practice continues to obviously promote the availability of that service to primary care colleagues. So I think the way in which that triage is currently undertaken does vary a bit between the hospitals. So so at the Norfolk and Norwich, that's mainly undertaken by sort of clinical nurse specialists or highly qualified nurses. At the James Paget, I believe it is done by either surgeons or by the gastroenterology consultant. I think what will really help with that is actually trying to agree a standardized form, and I'm so sorry to report that we've not been able to actually agree a standardized form across the 3 acute sites at the moment, where especially for upper GI non-2-week wait referrals, and there's and I think that the reason for that I won't go into here, but that is that is a significant barrier at the moment. Mark Follows, who's our GP clinical advisor for Plan Canada West, has actually done a triage of not triage, but a review of patients that were on the James Paget waiting list, and he did find that approximately a third of them could be removed from the waiting list or sent to alternative sources. So it is something that we are very strongly pushing as a clinical commissioning group, but I can be reasonably candid that we are encountering some opposition in relation to that.
Okay, thank you. Claire, is that a new hand? Yep.
Thank you again. Just another question, if you're kind enough, Mark, which relates to recent press reports just in this past few days, actually, related to the rising demand for private healthcare, which I suppose is understandable in many respects, given people know that many of the waiting times are significantly longer than they would have been in the past. But I was just wondering, that's obviously based on the ability to pay. So I was just really wondering about whether we were exploring any options to ensure that our specialist colleagues are encouraged to support recovery of NHS service provision as opposed to working in the private sector, because obviously in the NHS we prioritise on the basis of clinical need, whereas that's not necessarily true in the private sector.
Yes, Claire. So I'm not subject to those discussions internally within the trust as to whether or not they have any particular policies on consultants having a minimum number of sessions in their NHS practice prior to going out into their independent practice. So I'll take that up separately if that's okay offline. But thank you.
Okay, Hilary.
Just to go back to inequalities briefly, can I just put a request in that when we're looking at the inequalities data and why maybe the data doesn't look quite as we would expect it to, that we seriously look at pockets of rural deprivation, because we see in areas that are not entirely would be classed as a deprived area, there are significant pockets of deprivation. I just wonder if that accounts for some of the differences that you're seeing. I just wonder if we need a more nuanced approach really to be looking at deprivation and the impact of, for example, long waiting times on manual workers in areas that are not wholly deprived.
Thanks. Howard, do you mind helping me with that one, please?
Yeah, sorry, Hilary. I think that's a really good point, and it was raised at the Plan Care Board yesterday, and that will form part of the working group. Absolutely, yeah. I think that's a really good point.
John, did you want to add something?
Yeah, thank you. So, different point, but very well aware that money could be a key constraint in terms of us achieving the elective recovery that we need, just because of the scale of it. We're not yet aware of what the settlement is for the second half of this year or what the future arrangements will be, but I suppose the question mark would be, do you feel we've got a handle yet on the capacity that we could generate in the system if we raise our level of ambition? Because occasionally, as you're very well aware, as I am, there will be fairly short notice opportunities that come down to say there's some money available to support elective recovery in area A, B or C. So do you feel that we're on the front foot in terms of understanding what our potential capacity is so that we can actually leverage some of those opportunities?
Yes, John. So what we've got, and we didn't discuss it in detail at the Plan Care Board yesterday, but there is a spreadsheet which is maintained by Claire Houston in relation to, if additional capital funding or revenue funding were available, how could we potentially spend that? So just to give one example of something that we've submitted to the list is, at the moment, there are restrictions on ultrasound guided steroid injections, particularly in central Norfolk. And so myself, along with some other colleagues, have calculated, what the potential cost of that might be. There's a willing provider which is available to actually do those injections. And so we've got a line, in the spreadsheet, as it were, which we can submit as it were, and I've got the full paperwork for it as well, which says there's a provider ready to do this and these are the patients they would see. So we do have that. There's some which aren't quite as developed as that, but we do have some idea. So for example, one of the main constraints in relation to dermatology activity at the Northern Canary is that they are not able to find space to do super clinics, which would speed up the pace of them sort of seeing patients. And we know from other case studies in the region, such as Ipswich, that they really do help to do that. And so, again, we put lines in there, you know, even when we're not 100% certain which wall we'll be knocking down or whatever, to just be ready for that. So, yeah, so we do keep a database of opportunities, as it were.
Okay, thank you. Can I ask a question as well? Really useful discussion and report, and I think particularly focusing on what the current activity is. It's really useful to know, you know, what the capacity to get through these activities currently, and I think comparing it to pre-pandemic is really useful as well. But that's part of the picture, isn't it? Because it's sort of looking at current run rate. But what doesn't come out here, and I wonder if we're measuring and planning, is what the demand rate is. So you know, the input into outpatient referrals, into diagnostics from primary care, particularly because some of these aren't from primary care, are they? They're from secondary care as well. But have we got an indication as to whether within these activities we're kind of at current demand rates, or what we anticipate to be demand rates, because there's a backlog of need that's coming out after the pandemic as well? That was my first sort of reflection, and the second was, I know you've given us figures before, but this doesn't capture the actual waiting that people are enduring, and that's what patients you know when they've been waiting for a very long time, that they want to know when they're going to be seen. So have you got a sense of whether since July things have got worse, and which particularly those specialities are?
Yes, thank you, Niv. So in terms of the demand side, yes, we do capture that, and the area we monitor most closely for, as you can imagine, is the cancer referrals. I think for when we do have the data for other referrals as well from general practice. So off the top of my head, I'm able to say that for cancer referrals, and we usually had a baseline rate of about sort of 1,200 to 1,250 referrals a month going into Argy hospitals with that. And then in May, June time, that seemed to peak a little bit, and so go up to about 1,400 a month, and it is now settled back down to somewhere that's reasonably close to the baseline rate as well. And I can get information on the rest of the referrals you know, for the next meeting. Yes, you know, in terms of the waiting list, so overall size, yes, that unfortunately that does sort of continue to increase at the moment. So it's now at over 107,000 sort of patients across Norfolk and Waveney. So that is a significant concern, and I'm happy to include in sort of future update more of a breakdown in terms of the process, in terms of the clinical prioritization of those patients, and some of the actions in relation to the outliers. You know, for example, of those waiting over 2 years, 1 year, etc.
I think that would be helpful for future meeting, and I think it's quite right to focus on the urgent and the cancers in particular. And it'd be helpful to know, because there's a national campaign, isn't there, to get people to present, particularly those that might have not been able to present during the pandemic. So it'd be good to get some sort of benchmark on compared with other areas and where we should be in terms of cancers, particularly. Doris?
Yeah, I think this is kind of linked. It's really actually trying to understand the impact of increased emergency admissions that is impacting on the clearing the backlog, because emergencies come in, you know, then the list is just thrown for the day.
Yes, thank you. Thank you, Doris. So in terms of the emergency admissions, I think the area that is most acutely affected by that, is our orthopedic waiting list, because a lot of those are often one of the very earliest beds to potentially be used for non-elective admission. So what we've done is that we have got sort of external funding to use a system called System Dynamics. So essentially, there's a company that helps us do modelling for the system, and what it does is also trains up our local business intelligence team to be able to do that modelling themselves, using the website that they've got. And essentially, what we are looking there is one of the scenarios that is being modelled is, if we did ring fence a certain number of beds, what would the effect of that be, and what the effect of that would be compared to other interventions we might put in, such as everybody gets triaged, or 10% go to the community, and so forth. So we have agreed that the last workshop that we held for that modelling exercise last Friday, that should be one of the priority interventions that should be looked at. Anecdotally, the surgeons at the North Carolina report, well, normally they would have roughly 17 beds which they would dedicate to the use of orthopedic operations, and they're finding at the moment that those beds are being used quite frequently for non-elective. So I think once we've sort of done that modelling, which is a matter of weeks, not months, then I think we're in a much stronger position to actually sort of state things that are fairly definitive in terms of what, in terms of protecting elective capacity and how that will impact on our waiting lists.
Okay, thank you. So if there aren't any more questions or comments, we'll thank Mark for that report. I think that was a good discussion and just highlights some of the areas that we really need to focus on. So thank you for that. So let's move to item 11, which is a discussion on the current operational pressures facing the system. And is Rachel here, Rachel Peacock, to present that paper?
Hi, yes, I just joined. Hello. Thank you. I'm Rachel Peacock, Head of System Resilience with Norfolk and Waveney CCG, presenting today around the operational pressures and our planned approach to preparing for surges this winter. So a paper has been submitted with the pack, and I'll take it as read, that you've all seen and had an opportunity to read through that. I'd just like to draw your attention to one or two areas, if I may, to kind of illustrate the approach that we're taking. So perhaps a good example of the approach to winter planning for us is through management of the ambulance activity. You can see through the graphs that were included that we're seeing increases in ambulance activity of our acutes, and also increased delays in offloading patients, and we're having the way that we are approaching that, and kind of tactical response to it, is using digital solutions to improve communication across our system. And so we're monitoring flow through the hospitals using live feed access to computer aided dispatch systems used by eEast, and also our BI team in the STP has developed a live feed program for near real-time insights that gives us update every 15 minutes around the flow of information. So that means that we're able to have good quality access to data in order to provide or to plan the tactical response to the operational pressures that we're seeing. So there are regular locality-based calls, so place-based activity planning, looking at what demand and what needs to be done, and then also system level calls. And the system level calls are supported by an escalation framework, so that we're able to not only work on individual areas of our county, but as a system, at a system level, to plan and smooth demand and provide support between organisations. So that's an example of how the planning and the access to information is improving the operational. That's not my dog. And so the work that we're doing this winter is to build on that approach about how we are having a good level information around the pressures so that we can understand the capacity we have, the capacity we've got to move into surge against things like our workforce and the workforce pressures, bringing in things like the STP teams. So that we can build on the approach that we've taken with the ambulances to make a stronger and more sort of robust process right across. And so that will also involve things like extending with the system resilience function and also reinforcing the escalation framework that we use currently. We have I included a timeline for the responses around the winter plan. So we're expecting the winter plan to be the collation of the organisational responses to be put in at system level, hopefully by the end of October, so that we'll go to the strategic transformation steering group, which meets in mid-November, and they will be responsible for sign off of that plan. And it also mirrors the H2 elective recovery planning return timescales. So working very closely with Andrew Palmer around the elective recovery work, because clearly there could be a it's about maintaining both elements of work, so the elective programme as well as the UEC recovery. So that's probably is in terms of drawing your attention to the paper, probably the sort of key points to tease out from that from my perspective. So if there's anyone's got any questions that they'd like to ask, I'm happy to have a go at answering.
Thank you. Any questions, Kathy?
Thank you. And just to say, Anoop, you've gone very quiet. Hardly.
Okay.
So my question's a bit. So I read the paper, and I suppose what I was struck by was the level of detail that sits underneath this paper. And yesterday I was visiting one of our community providers, and they were talking about the increased volume of discharges from the acute sector into their community hospitals, and the increased levels of acuity, the increased levels of complexity, the increased lengths of stay because they haven't got anywhere to move them onto because they can't get the community packages in place. So when I read Chloe 5, it kind of looks really neat, and then underneath that there's a lot of stories, aren't there, of patients. And one of the things that struck me was that the community providers were saying they don't always get the right information with the patients because things are moving very quickly. And I guess my question is how within the is it very simple things that can tip this over and make things go wrong, isn't it? So I just wondered, within the context of the community capacity cell, how are we monitoring that we're actually getting it right for patients?
So you're asking about community capacity, which is really about the commissioning of community services for this winter rather than urgent and emergency care per se. So I'm probably not the best person to ask about that. But in terms of the, I know that for the discharge to assess pathways particularly, which is the outflow from our acutes, one of the areas of work that's happened is around trying to make sure that those processes are really robust, and that's part of the planning for winter, is about how do we make sure that those pathways are right and that the decision points are smooth and that they don't cause that there's no friction basically between teams as they move. And I think that's maybe partly what you're asking, Kathy, is about how do we make the patient's journey smooth, but you often make it smooth because your processes are good and in place, and that's part of the work that's happening at the moment, and it's being led by Nick Pryke, who's our director of discharge, and he's actually doing some pathway review work at the moment. So that work runs alongside and is obviously highly complementary to UEC because it's all part of the same system, inflow and outflow. But yeah, so there's been a process review. There are new pathways put in. Those pathways, the work that's happening through D2A, the transformational work, is also feeding into strategic transformation steering group, so that the whole umbrella of the group looks at both urgent emergency care pathways, but also the exit flow. So it's a much more cohesive approach.
Kath, did you want to come in?
Yeah, I thought I would help as well a little bit more to add on from what Rachel has said. So in relation to length of stay in the community hospital beds, we know that that has, over the course of the last 8 months, significantly raised. And a big part of our discharge challenges across both the acute hospitals and the community hospitals is associated with problems with capacity within the care sector. So a number of the patients who are in community hospital beds that no longer need to be there, and therefore that's extending the average length of stay, is because they need to step down to a different level of care, whether that's a residential care home setting or in their own home with support. So what we're finding is that the domiciliary care market is particularly challenged, not just locally but nationally, and that's resulting in then the services provided by the local authorities, the home care reablement services, are holding packages of care, and that's just causing a backflow within our different health settings. And it is felt that the increase in numbers of the length of stay and the numbers of people who should no longer need to be in a community hospital bed is as a result of that. But there is also the issue of raised acuity, and what we find when a system's under pressure is the threshold for decisions can sometimes change and resulting in maybe people with some increased acuity being transferred into the community hospital settings, but then they have to manage those complexities. But it is a real challenge for the whole system, and we are working with the local authorities to address the shortages with the care capacity. Some short-term actions have been taken to be more efficient in the way in which we use our home-based reablement services, so reducing the level of overprescribing or level of care that's no longer needed, and of course strongly encouraging the local authorities to be really proactive with their active recruitment. The other opportunity that we have is that there was, although be it quite last minute clarification for H2, that the hospital discharge programme would be extended into the second half of the year. So that will help with our joint commissioning of care. But it's a lower amount than it was in H1, and there will be an end point. At some point, the additional monies that are coming in will stop, and there will be an expectation that systems will be able to be more resilient and self-sufficient within their existing budgets. And I saw John nod in, so I think he's on the same wave as me that the money will come to an end. So hopefully that helps, Kathy, in terms of answering your question. Sorry if I was long-winded.
Okay, thank you. Can I just check that people can hear me, because I might have been having problems with my microphone.
Now, yeah.
Oh, yeah, it had turned down for some reason. Melanie, and then Hilary.
Thank you, Anoop. I just wanted to add maybe a different perspective to the paper, which is to give the governing body some assurance around the planning approach for winter 21. And I think it would be helpful at the next governing body meeting in public for us to have more detail on the key areas of action and the areas that we're looking to try and strengthen and improve for patients' experience and the quality of care, because we know that Norfolk and Waveney has seen just really high levels of activity, high numbers of patients presenting in all aspects of our services, in general practice, in A&E, calling 111, and high numbers of ambulance conveyances as well. So it's across the board. This is a national picture. We are seeing higher levels of patients presenting compared to pre-pandemic. And so given that, what are we going to do to try and ensure that our public have the best possible experience, quality of care and outcomes. And I wanted to just mention, although this may seem like quite a basic area of focus, we know that campaigns and communication campaigns to increase the profile of 111 does have an impact on what other parts of the system are seeing, and even the use of pharmacies and asking pharmacies to do more. So I know Paul is planning a lot around that to try and encourage people to seek help from areas where they can actually get probably a faster response than going to many areas. And I think that's important. And as was mentioned earlier, we haven't had the planning guidance yet for this next half of the year. We also haven't had our financial allocation for this next half of the year, and expecting that any day, hopefully, but that will then give us some confirmation of what resource we're able to invest in our approach to winter. And so I would like to suggest a further paper on this, but one that is really focused around quality, access and patient experience, and as well as highlighting the very, very high risks that we are seeing in the system. Thank you.
Okay, thank you. Hilary?
Thanks, Nick. Thanks, Rachel. I'm quite interested in the level of tracking data that you seem to have on patients as they move through the system, and clearly there's a lot of clever information underpinning all of this. I wonder how much of that could be brought to bear on the clinical information that's transferred, because every time a patient moves across a clinical boundary, there is a risk and a safety issue to an extent. And one of the problems that we're seeing in primary care quite a lot is that with the increased activity, you don't always get timely information, and there is obviously a clinical risk to that, a patient experience risk to that, but also risk of readmission. So I just wonder whether with the clever tracking data, there are any processes or any learning that can be brought to bear on the transfer of clinical information.
So the information that we have at the moment, and you're absolutely right about the tracking of patients, and some of it is about knowing which services patients are accessing and how many times they may have gone to that service before they then perhaps present to A&E. And so we are very mindful that that is extremely useful, certainly to understand the flow of activity, so you can have the right operational response. The information you're talking about is more about how do we share information across providers, and some of the transformational work that's happening at the moment, for example with 111 who are booking patients directly into ED, we're working on how can we make sure that the digital pathways match and can transfer information in the same way. So that's part of the transformation work that's happening is very mindful of exactly that, is helping patients to tell their story once and for that information to move with the patient. And so the BI team at the moment are working closely with us and other areas of the system to look at the feasibility and how that can work. It's also part of the NHSE regional work programme in terms of the booking and how we access how we move patients between services so that they can access things like the same-day emergency care pathways, and how we can move the patient record with the individual. So they're the pieces of work at the moment that we're very interested in and are being explored as we speak.
John?
Yeah, thank you. Just a couple of comments. Firstly, on that last point, Hilary, that there is a programme of work across the system to scope and develop and procure a shared care record approach, which will enable clinicians, operational staff in different environments to see information from other organisations. Unfortunately, the timeline for that at the moment is looking at 12 months plus off. So we're challenging certainly the team to say what's possible in the shorter term, but it sounds unlikely that that's going to help this winter, which is a shame. So it does feel like tactical solutions are necessary, but there is a glimmer of light at the end of the tunnel. There should certainly be an approach from next year that would help. Just commenting on some of the financial elements discussed earlier. So as Kath said, the hospital discharge programme, we've had verbal confirmation it will continue for half 2, but quite clear verbal confirmation that's it, and it will stop at March next year. We don't yet know what that means, but as Melanie said, when the guidance appears, hopefully, we're told it might be today, it might be tomorrow, it might be Thursday, that might signal something more. But I was going to kind of pose a question which might have been covered by discussion earlier, but in the report, Rachel, it mentions under the risks, the finance risk, that UEC will require additional investment in streaming, 111 call handling capacity and support for social care, which absolutely recognise as being pressure points. But the context I'm looking at this through is we're taking a presentation on system finances to Julian Kelly next week, the CFO of NHS England nationally, and what we're saying is the biggest reason that we've got a gap historically is because we've invested in things that we can't afford as a system. So I suppose the question would be, have we considered what option B would be if we don't get extra money for those things and how we could do things differently? Of course, when the planning guidance comes out, it might say nothing to worry about, here's some money, but
yeah. Absolutely. So whenever, when you identify where a gap is, you also need to think about prioritisation of the services that you are putting forwards. And so part of the winter planning or the winter surge planning, we've made it clear that as a system, organisations need to think about what they can do within their current expenditure around working differently to create the resources for surge, to manage surge. And what we saw during the COVID response was some really good evidence of examples of people working really differently. So, for example, a small increase in beds with an existing registered nursing stock in the community units, for example, to accommodate 1 or 2 additional patients that could be done without upsetting the particular organisation, and it helps to balance risk across our organisations by having a small amount of risk across organisations rather than a lot of risk in one or 2. And so, very, very much so, it's about what's the art of the possible with what we have now. So it's using our resources, and I think that really kind of comes back to the backbone of the winter planning this year, which is what do we have already and what could we do with what we have better. And a lot of it is about addressing the resources we have and joining it up well, and so the system working particularly comes into its fore at that point. So rather than each individual organisation working along and reaching a tip over and surge point, by having good level data, you can intervene earlier so that you've got a good tactical response early on when an organisation is escalating, and then you can balance risk across organisations and can balance the workload, so that you're not having to put dozens of extra beds in one organisation, for example, but then you can share risk across by, for example, rediverting ambulances, so that you can even out your flow. So that that really is the sort of backbone element into the plan.
Thank you. You're on mute, Anu.
Thank you. There's always, at least once that happens. There's always someone with a dog as well. Thank you. Thank you very much, Rachel, for that update and the discussion. And I think we'll want a further update at the next meeting when some of the questions around funding, particularly in capacity planning, are a bit more clear. So thank you. Let's move on to item 12, which is to review the recommendations and approve, hopefully, the recommendations from the on clinical thresholds. Mark, do you want to talk us through?
Chair.
Yep.
Thank you, Chair. So there's 5 clinical thresholds for approval today. So 2 are unchanged from previously and have just been brought due to there being a regular review date. So first is the functional electrical stimulation policy, which we had a quite good discussion about last year, I remember. And secondly, the acupuncture. And then there are 2 policies with relatively minor amendments. So the first is in relation to incisional hernias. So the original wording policy stated that conservative management should be tried first, and I think the intention of that was to try to get people to lose weight before their surgery. And obviously that still stands, but obviously losing weight won't necessarily stop someone from having an incisional hernia, and it won't resolve with that. So after discussion, the group decided to remove that as a clinical threshold criteria. Just similarly in relation to carpal tunnel syndrome, I'm aware that we've only discussed this sort of fairly recently at governing body, but based on the initial referrals, based on the new threshold, or the most recent threshold, the surgeons have advised that we don't feel it's necessary for us to insist on nerve conduction studies prior to the referral patients of mild symptoms, and they're able to proceed on the basis of the patient's symptoms, which will be a good thing in terms of shortening that patient's pathway and obviously not adding to waiting lists and potential cost in relation to nerve conduction studies. Finally, there's a policy in relation to CT guided nerve root injections. So that relates to a procedure that's not normally undertaken or referred to by primary care physicians. And so we worked with Dr. Geeta Kapoor and other colleagues from Norfolk and Norwich. We had in turn liaised with radiology colleagues at the other two hospitals to agree a policy in relation to that, but those will mainly refer to how other specialists refer into that service as opposed to what GPs refer. But it is a service that we commission, even if it's referred to by another specialist. So that's why it's before us for ratification. So I'm very happy to take comments, and I recommend approval. Thank you, Chair.
Okay, thank you. So any comments on what we're asked to ratify? Tracy.
Yeah, very, very quick question. So in respect to the policies, yes, they've had that thorough clinical review, I'm aware of that, but just to, as they've been kind of refreshed, do we do in each case an inequality impact assessment on each one? Is that undertaken just to reassure members that that takes place as well?
We don't do a formal inequalities impact in terms of filling the template for each individual policy, Tracy. I mean, what I've tended to do in the past is to take them as a job lot and do an inequalities assessment of the whole thing, of the whole program. So I think it's a while since we've done that. So I'm happy to take that as an approach, which we could do, via the CPTG if that's acceptable.
No, thank you. That'd be great. Thank you.
I suppose a review of impact assessment, and whether it continues as it is, I guess. Okay. Any other questions or comments before we ask to approve? No. Okay. Well, can I then ask you to ratify the recommendations that have been requested? Yeah. Okay. So I'm taking that as a unanimous. Thank you. And then item 13 is to review and approve recommendations from Drugs and Therapeutics Committee. And we've got Michael here. Yeah.
Okay,
well,
thanks,
Michael.
Anoop. Yep, thank you. So this is our regular paper from our Area Prescribing Committee, Norfolk and Waveney TAG, who looks at the evidence for the cases put forward either by NICE or by local consultants, and recommends a traffic light or a commissioning recommendation, which then goes to Drug and Therapeutics Committee, and they put forward this paper summarising those. So I won't go through the detail as such. I'll take the paper as read. Just one thing I'd like to highlight is NICE Guideline 196 on atrial fibrillation diagnosis and management. NICE have changed the recommendation on the tool we use to assess bleeding risk in atrial fibrillation prior to discussing the risks and benefits with patients on bleeding versus the benefits of anticoagulation versus the bleeding risk, which in almost all patients, the benefits outweigh the bleeding risk, but they're now recommending the use of the tool Orbit, which we believe is on most clinical systems through Arden's templates, and that will replace the older tool HasBled, which was slightly less specific for for the use of DOACs. So happy to take comments and hopefully you'll approve the paper.
Okay, so can I just check on the on that atrial fibrillation, that tool, if it's available through Ardens, then most practices will have access to that. Is there also a quality framework requirement, and will that also be translated into systems?
Good question. There is a nice quality framework that sits alongside the NICE guideline, as it does with all of them. So that will be something that possibly CQC might be interested in when reviewing, because they're quite often interested in how well DOACs are monitored, etc. It may be something they wish to review and seek assurance that practices are using the recommended tools. That I'm not too clear on. I don't know if other members of the clinical members of the committee would like to comment.
I don't know if any of the GPs are aware. Is Hasbled is that part of QOF?
I don't think it's part of QOF, but I think Orbital is definitely included as part of the Ardens template, and I think a clinical tool.
Okay, so that shouldn't be an issue in terms of implementing it. Thank you. Claire?
So I was just about to say yes, Orbit, I've seen it, I've used it, as is the tool for calculating creatinine clearance, which is pertinent with that class of drugs as well. They're both together on the template.
Okay, great, that's reassuring, thank you. So if there aren't any further questions or comments, can I ask you to approve the recommendations that have been made by the Drugs and Therapeutics Committee? Yep, okay, so that's unanimous. Thank you. We're up to item 15, which is an update from Kath and Arden on eating disorder services. Yep.
Thank you. I'll start if that's okay. It's a bit of a double act, as you've said, between Arden and I. We'll switch back and forth, but aim to not spend too much time presenting the paper in order to leave time for more detailed discussion. But just in terms of the context, in the autumn of last year, we attended as an interested party a coroner's inquest from Cambridge and Peterborough into the death of person A, who died in 2012 as a result of anorexia nervosa. I wasn't planning to go through the timeline events that can be seen for information in Appendix 1, but the coroner released a prevention of future death report, and that is what this paper is focusing on in terms of our system response to the actions that were identified, the recommendations and directives identified within the prevention of future death report. Also related to the same case in 2017, there was an investigation by the Parliamentary and Health Service Ombudsman and a subsequent report named Ignoring the Alarms, how NHS eating disorder services are failing patients was produced. So this paper aims to identify key areas of focus as a result of the recommendations and required actions from both of those papers. They were all directed at a national level, not specifically applicable to Norfolk and Waveney, but we've attempted to identify how our local system has responded, particularly in latter years, to those improvement requirements. So in terms of the prevention of future deaths, the concerns that were raised from the coroner, he identified that unless and until the following concerns are appropriately addressed, there remains a risk of avoidable future deaths. And so in essence, there are key actions which, as I said, don't just apply to Norfolk and Waveney, but clearly are relevant to us 9 years on. So I'm just going to go through some of them along with Arden, and I won't attempt to read out everything, but some of the key themes picked up relate to inadequate training of doctors and other medical professionals, and indeed other healthcare professionals. And he highlighted that there was widespread and continued lack of training, knowledge and experience on the part of clinical staff regarding eating disorders. And actually, a significant shortage of eating disorder specialists across the county. Arden, can I hand over to you to talk to 2.2 regarding medical monitoring?
Sure. So the coroner also pointed out that there was a lack of effective medical monitoring along with most systems nationally, and that this needed to be addressed. And helpfully, this was also picked up by national NHSE guidance, NICE guidance and NHSEI guidance, which was very clearly set out the roles and responsibilities of both primary care and secondary care in terms of providing medical monitoring, with suggested model being that primary care provides medical monitoring for low to moderate presentations, and secondary care picks up the more complex medical monitoring cases and provides support and advice for primary care. So with this in mind, we have revisited our local model in terms of medical monitoring, and looked again at the LCS, which was existing prior to this, in order for more areas to pick this up as a PCN type model. So we reviewed this as a clinical collaboration with representation from all across Norfolk and Waveney, and it was agreed that we tried to offer this amongst all PCNs with a view to us implementing the national guidance as soon as we can skill up secondary care services and provide the infrastructure to deliver the more complex monitoring. And so that's what we're aiming to do over the coming year. In terms of the data, again, this was picked up by coroner and nationals, that national systems are just not picking up numbers of people coming forward with eating disorders, and particularly the complexity of those cases. So again, looking at our own data to make sure that we are assured that we have the correct data in place. And currently we do report really well on acuity, on caseloads, waiting times and workforce. And that's looked, and that data is, as a local system, is reviewed very regularly.
Thank you. Whilst it wasn't relevant to 2012, but the coroner did actually express real concern about the impact of COVID-19 on the impact in our population with regard to eating disorders and disordered eating. So he did issue a PFD recommendation about the impact with regard to the risk of future deaths as a result of the problems that have been exacerbated by the pandemic. So in terms of the section 2.4 of the report, underpinned by one of the appendices, which gives a bit more detail on the data, what we can see is both across Norfolk and Waveney, but this is reflective of regionally and nationally, the challenges, significant increases in demand, both in terms of the numbers of people presenting with an eating disorder, but also the acuity of the people that are presenting. So we can see that's set out in that section, comparing quarter 3 2019-20 to quarter 1 2021-22, there's been an increase of 85%, and actually for the urgent referrals received for people under the age of 19, there's been a 4-fold increase in the number of referrals, and again reinforcing this issue of the complexity and acuity is much higher than before, and actually seeing more people presenting for the very first time with their eating disorder directly to emergency departments who there are needing to be admitted for medical stabilisation as a result of the consequences of the eating disorder. And alongside that, there is a regional and national increased demand for and subsequent shortage of specialist eating disorder beds, both for children and adults. Some of this has been affected by COVID, so some beds have been closed because of outbreaks, but actually the acuity of individuals, particularly those requiring nasogastric feeding, has resulted in people staying longer in the beds because of the acuity, the complexity of their case, but also the workload associated with dealing with people with that even greater level of need. So within the local system, we've brought together all of the partners involved in providing care to people with eating disorders, and have a very collaborative approach, which includes myself personally and senior members of my team getting involved in very complex cases to support the system and the patients to avoid patients falling through the net in relation to not being able to access services. And that has been and continues to be really quite challenging, exacerbated by those national shortages of specialist eating disorder beds for those individuals that do need that. In terms of section 3, just to say we've picked up on some of the actions, but what we haven't done is duplicate where there's crossover between the prevention of future death reports and the Ombudsman, but we've picked up on some of those recommendations. I'm going to hand back to Arden for section 3.1, please.
Thanks, Kath. So the Ombudsman was very clear that services should be equitable both for children, young people and for adults. And to that end, we have invested as a system an additional £1.4 million to strengthen adult eating disorder services, which represents a 50% increase. And we prioritise this in our community mental health transformation. Some of the additional interventions that we've already put in place are investing in the FREED model all across Norfolk and Waveney, which is an early intervention model, picking up people as soon as they present with a new eating disorder and prioritising those people in order that therapeutic interventions can be put in place at a really early point in their illness, which we're really hoping will lead to them not progressing towards entrenched illnesses. We've also invested in the community, in the clinical associate psychology role, which is something that the UEA will be starting training the first cohort this autumn, which we're hoping will be able to populate some of those clinical posts and therapeutic posts, which we know we need to support the teams. And we've also invested in carer support as well. Our community-based intensive support service is also being designed at the moment to incorporate such things as supported eating and hubs also within the communities. And in addition, we're working through the transition model so that our new service design is as much as possible avoids transitions, with it being an all-age service with therapeutic interventions designed to meet need rather than based on what age that person is when they present. We've also, as Kath said, we have a regular meetings between the providers to discuss complex cases and also to share learning and to ensure that system pressures are discussed and responded to. In terms of our strategy, which looking ahead, we've had a series of meetings over the last year to really start to formulate our strategy involving a really wide range of stakeholders. Really pleased to say that attendance has been excellent, including experts by experience, and we've also held a number of listening events for workforce groups and from experts by experience to really understand where the gaps in service provision are and where we want to meet those, to fill those gaps going forward. And we're also linking very closely with our colleagues in region and in NHS England who attend those meetings so that we can link in with the work of the provider collaborative as well. Our vision, our ambition is for a single point of access for all people with eating disorders, including with the voluntary sector being part of that, so Eating Matters being very much part of that, so that we can signpost people to the most appropriate care, again, regardless of their age. Also developing alternatives to admission across all ages, and incorporating for the first time ever avoidant and restrictive food intake disorder pathways, and very importantly, including people with learning disabilities and autism across all of our pathways as well. And this is a system-wide strategy. So I'll hand back to Kath for our summary.
Thank you. I'll just pick up first on the governance arrangements. So Appendix 3 contains a governance structure for the oversight of eating disorder services. So you'll see that reported into the Mental Health Partnership Board but also we are active participants in the Regional Strategic Board for all age eating disorders. And then from a CCG perspective, then of course we have the Quality and Performance Committee and the Clinical Executive Committee, where there are clinical pathway discussions to take place, which then both report into this meeting. Also to say, young people's, so the Children and Young People's Programme will now be reporting through into the Mental Health Partnership Board. So it's not just going to be focused on adults. So we'll be looking at how we make sure that there is that coordinated all-age approach to system-wide oversight of all-age eating disorder services. So in terms of, to summarise, the tragic death of A in 2012 was clearly as a result of inadequate provision of coordinated and robust services across primary, community and acute organisations, and that includes specialist services. And the coroner in 2012 determined that the death of A was avoidable and it was contributed to by neglect. There has, however, been considerable improvements and investments in the service, particularly in the latter years, but they need to continue at pace to ensure that we deliver best practice services to meet the needs of our population, taking into account particularly the concerning increases in incidence and level of acuity of people that are presenting. And we have built strong foundations across the system, and as Arden said, whilst obviously we will continue to support people with very complex challenging needs, but also the focus on prevention and early intervention is key to transforming people's lives so that they are more likely to be able to live lives without the concerns, the impact of living with a long-term eating disorder. And one of the things I wanted to say quite clearly is the impact of the death of A and the learning, not just locally in Norfolk and Waveney, but actually nationally, is directly influencing improvements in the services and provision for eating disorders. And it's actually a legacy that will make a difference to local people and people all across the country. And some of the at the bottom of section 6 sets out, as I say, prevention and early interventions, making sure that we continue to work collaboratively as a system, working to an all-age strategy so that we don't have the cliff edges depending on people transitioning from children's and adult services, and working to ensure that our medical monitoring service meets the requirements recommendations from NICE and NHSEI, and that we will engage with people living with an eating disorder and members of the public to listen to them and understand what their needs are and how we can improve services, continue to improve services for the better. So recommendation as set out in section 7, asking the governing body to note the findings and the required improvements in both the PFD report and the PHSO report, which are both directly influencing the local programme, and that includes the governance arrangements that I've set out earlier in the paper. So thank you. I'm happy now for Arden and I to take any questions or comments.
Okay, thank you, Arden and Kath. I've got Tracy and then Claire. And
yes, then thank you, Claire and Arden, for a very comprehensive update and overview of where we are currently. And I can see, lots of improvements are taking place, which is really good from where we have been before. So that's excellent. Just thinking about the prevention element, I particularly guess that's with children and young people, how we're embracing and supporting and collaboratively working with schools and education, colleges. So that really, really early pick up of where there are disordered eatings, certainly working with families to pick things up really, really early. So what's our focus there? So that's my first question. And the other question is in respect of clearly there is an increase in demand, and just where we are currently, how are we kind of managing with that increase in demand at the moment? So just a brief update on that, if that's at all possible. Thank you.
Thank you. If I pick up the first question, and then Arden, do you want to pick up the second one, if that's okay? So in terms of our investment plan and in service improvement plan, that does include teams to support schools particularly, but that also extends into colleges. to work with supporting teachers to identify children who are at risk, and in order to take forward that early intervention. So I'm not suggesting it's widespread across the whole of Norfolk and Waveney at this stage. We're in the early stages of that programme, but you're absolutely right. We don't want to wait for children to be referred by parents to their GPs. There are other ways in which children may present, and whether it be to their teachers, school nurses, etc. And so the teams that are being invested in as part of our improvement programme includes that support to the education system for that purpose. Arden, would you pick up too?
So in terms of demand, yeah, we absolutely recognise that demand continues to increase, new presentations continue to increase, and also people are presenting at a later stage and become at a more unwell stage of their illness. So we recognise that. In response to that, we have had a workforce recruitment drive to try to increase numbers within our teams. It's fair to say this is a really difficult area to recruit to. It's a very challenging area. And so we're very conscious that we want to retain our staff and support our staff. And so there's a lot of emphasis on supporting the workforce and supporting the teams. We are looking at potentially some memorandums of understanding to bring teams together, because as you know, we have different providers for the adults part of the service. So we're looking at how we work much more effectively, and certainly with the new strategic model about how we can have therapeutic interventions not based on teams but based on need. And so, you know, perhaps somebody in one part of Norfolk can provide it for a patient presenting in another part. So just looking at how we can really be flexible across all of our teams. Also some exciting thinking going on with the training hub around potentially developing some GP fellowships. So for people who might have an interest in eating disorders working within general practice, to also support the clinical element to those teams. But I think it's fair to say this is a very difficult area, and it's one that we are aware of and doing our best to respond and recruit to.
Thank you. Claire?
So thank you to both Arden and Kath, first of all, for raising this as a concern. Again, quite harrowing reading, and a lot of sympathy and condolences to the affected families. I've come across people with eating disorders in a number of specialties in my training in general medicine before I became a GP, in the time I spent in psychiatry whilst training to be a GP, and my time in primary care since being a GP. So a number of things that struck me when I read the report. One was about the need for training across specialties, so not purely for those who are involved in the active management of people with eating disorders, but actually more broadly, because people with eating disorders can present to a wide number of different specialties. And I think it's important that we raise that profile and the importance of actually being on alert all the time. The second thing that you caused me to do, and again, I'm going to thank you for making me do this, is I went back to read the NICE guidance on managing eating disorders. I suppose in a way I kind of felt, I sort of thought that my personal knowledge wasn't bad because I'd had previous experience of it. But when I read the NICE guidance, it struck me as being potentially deficient in a number of key areas. So, for example, if you read the guidance around what is intended or what the advice for GPs is, there's a real paucity of information it gives as to what would be appropriate. So, for example, it says that GPs should offer a review at least annually, which clearly in a situation like this was far from adequate. I also think it perhaps lacks detail in terms of care planning. Again, there's a little bit more for planned discharges from inpatient care, but it doesn't really give very much more detail, and it probably doesn't discuss the importance of communication between services as much as it should. So one thing I wonder if we should do as a system on the back of this report that you brought to governing body today is actually raise a concern with NICE, particularly in view of the report from the Ombudsman, because the guidance was only updated in December actually, but I do think it could give a lot more detail and a lot more clear instruction and actually some more flexibility, so that actually the instruction is tailored to the individual needs, not a directive that applies regardless of need.
Thank you, Claire. I mean, yeah, very insightful comments. I think in terms of the training, I absolutely agree. This is eating disorders affect all areas of medicine and society, and so very much part of what we're trying to do is establish training programs for all people involved with the care of people with eating disorders, and particularly amongst the community teams as well, in NSFT, in all the mental health community teams, but also secondary care programs of education, and, as you know, primary care education too, which is taking place very regularly. And that was picked up in the PFD report, actually. In terms of our interpretation of NICE guidance, it's part of the review of the LCS, we incorporated the King's guidance, which is much more explicit about what's expected clinically, and we put that in as an appendix and to the LCS for people who have adopted the LCS, so that they should be clear. But we've also been very importantly recognised that the community eating disorder teams also need to be able to provide round-the-clock advice and guidance for primary care managing patients, and that needs to be very responsive. And to date, it perhaps hasn't been as robust as it could be, and that's something that's very much we're aware of, and absolutely need to strengthen that, so that advice is available at all times.
Okay, thank you. Rob?
Yeah, thank you, Chair, and thank you for the report. I was reassured, Arden, by your comments around the scrutiny of the data, because I think that's important. And again, it's pleasing to hear some of the actions that are being taken and some of the planned actions. What I find worrying, though, Kath, about the trends is the increasing demand, and particularly the trend that you're seeing in younger people. What that led me to wonder is whether it's possible to use the data to predict future demand, so that we can line up our services with that future demand and keep ahead of it, rather than trying to catch up with it.
Thanks, Rob. I completely agree about the concern about the increased demand and the trend. The challenge with regard to the future modelling is what we don't yet understand is the legacy impact of the COVID-19 outbreak and the consequence to people's mental health, particularly, I would say, children, young people, the loss of their the only control that some of the young to mid-teenagers had was maybe what they ate, and I think we're yet to see the consequences of COVID outbreak. So I think there is some national work that we would need to seek out to see if there's any national modelling of whether or not this trend will continue, go up, whether it will flatten or actually indeed go down. It's really, really hard, unless Arden's got anything else to add. It's really hard to understand what's going to happen, because we've got no similar national incident to compare it to see what the impact would be. But I don't know, Arden, have you got any thoughts on that?
I think the other thing that we're really aware of is the role of social media, and how much hold that took during the pandemic as well. And I think that's influencing some of the behaviours of our young people, and that's something that, as a society, as a community, we need to try to address. But yeah, it's very worrying.
Yeah, thank you. And Kathy, I do understand the difficulty given what we've been through in the last 18 months, and I couldn't help thinking, Arden, about social media as well, and some of the impact that that's having, and whether there's a way of trying to address that separately through the organisations that provide social media. Thank you.
Okay, thank you.
Can I just add, though, sorry, as well, to say that even if we're not absolutely sure about what the modelled activity profile is going to be, we are continuing to invest more money year after year in adults and children's eating disorder services, which will increase the number of people that work within those teams. So taking into account the staff, the challenges of the recruitment, but actually more creative approaches to recruiting into these teams are being taken. So as Arden mentioned earlier, 3 of the new clinical associate psychologist roles are being recruited to in the adult eating disorder services, but actually 19 whole-time equivalent additional staff in the adult services are coming online. So we are trying to use best judgment to identify the additional capacity and range of staff that are needed within the services, even if that isn't exactly modelled to a known entity over the next couple of years.
Thank you. Melanie, did you want to add to what's been said, or because Doris is waiting as well?
I wanted to make another point.
All right. So I'll ask Doris to make a comment then. Thank you.
It's linked actually to the previous discussion about communication, and I kind of can't help wondering, you know, what can we do to actually encourage people to seek help before it's really serious, and it's, you know, whether actually we can improve the communication of, you know, warning signs, both for you know, friends of young people who might spot it and might encourage them to seek help, and for parents and carers. But once we've done that, do we then actually have the resources in place to support the people who are, you know, who are going to present early? So, you know, it could create even greater demand, but hopefully that will then reduce the sort of acuity that people are presenting and the need for, you know, really serious support.
Doris, that's absolutely right, and that's what the Freed model is all about. It's about picking people up at the earliest possible opportunity, so that those behaviours don't get entrenched, and working with people really early. And so far, the evidence that we're seeing is very, very good, and we're really hopeful that that will make a big difference.
Thank you.
Can I just come in on that, So does the Freed model actually help people to identify that they might have a problem, rather than, you know, it's a fine line to sort of, you know, the early warning signs to try and nip it in the bud earlier, rather than they're not well?
I think the fact that we have this service raises the awareness across the board, so there'll be greater awareness in colleges and schools that this model, this programme exists, and I think that will help people to have those conversations earlier on than perhaps they might have done.
Thank you.
Can I just add, though, I think there's your comment, Doris, about, you know, doing more, doing better at communicating out to the wider public is really important, and we take that back and look to continue to use really creative ways of communicating with whether it's the young people themselves, whether it's schools, whether it's parents. I think there is always more to do, and we will take that back.
Yeah, thank you. I completely agree with the last point, Kath. There is much more we can do, and I think wherever possible, if we can keep the names of models that we come up with, which mean something to us but not to the general public, like the Freed model, and name it for what it actually is, so that the public of Norfolk and Waveney understand where they can get help for someone they care about who may be showing early signs of eating disorders, and use as many different approaches as possible, including schools and colleges, but not exclusively. And I was going to just mention the National Charity Beat, which has fantastic information on there for patients and families and young people themselves. So we must include that as well. And I think when we group together this term young people, there is such a difference between how a 12-year-old might engage with a service and how a 17-year-old might engage with a service. And we need to have different approaches for example, those two. You know, the 17-year-old is less likely to listen to their mum than a 12-year-old. will. And I think wherever possible, we should test out young people's views about how are they experiencing services. And to do that now, that's something I would really like us to do, especially with all the new services that we've put in place. We know that young people are often restricting their eating as a way of managing control. Therefore, it's really important that they feel like they've got control over the service and the care that they're accessing. Thank you.
Thank you, Melanie. Hein?
Yeah, thanks Arden and Kath for an important note and good discussion. I would echo the comments made on social media and working with schools and colleges. It mentions in the summary that you're engaging with people living with eating disorder and the wider public. Have you given consideration to include an expert by experience in one of these bodies that are mentioned in Appendix 3? Because it might help a sort of sense of reality sort of at the point of decision making.
Thank you, Hein. Yes, and in the paper we talk about engaging with both existing and previous service users to get the views of those people that have an eating disorder or disordered eating, or people that have had have been able to become more well with their eating disorder and learn from those experiences of what went well and what didn't go well for them on their journey.
Yeah. No, I agree, Kath, but it's more at the point of decision making, so maybe even at the table where you're making governance decisions. Just to
reassure you, we are. So at each point of at every meeting, we have experts by experience. We also have separate meetings where we discuss all the new transformational areas with them to ensure that it feels like a good fit for them as well. So as much as possible, we're reaching out and including to young people as well. So the Young People's Partnership Board are also very much involved in feedback. And if they don't wish to attend meetings, we've also had an online a form that they can complete just to help us really shape our services. There's always much more we can do. And I totally take Melanie's point about, you know, absolutely children, young people must have that opportunity to take control of their care. And so, yeah, the more creative that we can be in terms of engagement, the better.
Yeah, thanks.
Okay, Doris, do you want to come back?
Yeah, it was just using people who have actually experienced, you know, eating disorder or disorderly eating. I certainly know of, you know, some friends of ours. Their daughter sought help because somebody who previously had suffered from it saw her in the supermarket and dropped a note in her basket. And actually, they are really powerful advocates of actually what can be done to help people and how can we tap into that resource to help our population.
Thank you, Doris.
Yeah,
really
thank you. Okay, well, if there are no further comments, I just want to say probably spent a bit more time than we'd allotted, but I think that was a really worthwhile discussion about a very serious topic and one which locally we know, you know, where things went badly wrong, and we've got to make sure that that wherever possible, tragic incidents like what happened previously don't happen again. I think what the discussion has shown is that it is very complex, and there isn't a single answer. But why would there be if there's a complex situation? And I think what it demonstrates is that it's the focus that we need on this to recognise it as an important issue and to deal with situation as it emerges and changes. So dealing with social trends, how we communicate with people, and as events happen. So the consequences of COVID, for example, we're only just discovering in other areas, but in eating disorders, I know, and we all know that's going to have an impact on this service as well. So I think it's important that we have that constant focus and to recognise the importance of it. So thank you for that debate, and thank you Kath and Arden for facilitating it. Let's move on to item 16, which is month 5 report from our finance officer, John.
Thank you, Chair. So I'll take the report as read. Just a couple of things I wanted to highlight. This is the finance report as at 5 months into the financial year, and we were reporting as a CCG an adverse variance of the best part of £4 million after five months. And the key things driving that were pressures on continuing healthcare and GP prescribing. The context is the interim financial regime that we've got, where there were specific uplifts allocated to CCG envelopes for both those services. They were very low uplifts compared to the pressures that we're seeing. So it's not surprising in that context that we're overspent at the moment. We're also expecting at the end of this 6-month period, because at the moment the NHS is working 6 monthly financial envelopes and planning approaches. We're expecting that gap to grow to the best part of £6 million by the end of month 6. It's worth noting that despite pressures in the CCG, the system as a whole is delivering a balanced position as at month 5 and expecting to balance as at month 6, because there are underspending provider organisations locally which are helping to offset the CCG position. Clearly, as we go through the rest of the year, we'll need to understand how that changes, if it changes, because it's important that we still deliver our statutory duty as a CCG, which is to break even. Couple of other things I mentioned. We've already alluded earlier in the meeting to the fact that H2 planning guidance and H2 financial envelopes are not yet published. Verbal indications have been out with us for a few weeks now, but we haven't had the actual detail published yet, so I'm not able to update the governing body on what that looks like. Sincerely hoping that will be with us this week, so obviously the period that we're talking about, the second half of the year, starts on Friday. However, I think it's well worth noting that the approach of the system and the CCG to efficiency and productivity is significantly ramping up from that which we've seen over the last 18 months, and has been entirely appropriate over the last 18 months as efforts have focused on the pandemic and operational pressures. So we're expecting greater requirement for efficiency in the second half of this year and going into next year. So we are reinstituting proper PMO processes for savings programs within the CCG, with fortnightly oversight within the exec team, effectively through performance review meetings. So we're obviously focusing on that, having more updates on that through the Finance Committee. I'll leave it at that. Happy to take any questions.
Thanks, John. Any questions for John? Claire.
Other than, I guess, the obvious one is my concern about the potential for efficiency savings at a time when we're trying to stand everything up after the pandemic, and just, you know, I suppose acknowledging more than asking, because I'm sure we won't have the answers to everything, about how we make those difficult balancing decisions. And, you know, if we are asked to make efficiency savings, how we do that without having an adverse impact on the recovery position.
So just comment on that, if that's okay. So couple of comments I've made. Claire, I completely agree with you and recognise that. So the two areas within the CCG that we're focusing on for efficiency are continuing healthcare and prescribing, and in both circumstances we're having conversations about where can we bring capacity in actually from outside the organisation to support, because both of those teams are flat out dealing with business as usual and pandemic related responses. So we're absolutely looking at that. I suppose two other comments. One is referring to what I said earlier. It's good that we're looking at things as a system now. So where there are benefits elsewhere in the system that can help, we've got that approach and ethos that actually money does move around the system to support any particular organisation in difficulty. We've done that over the last couple of years, so there's also the potential for that this year. And also we've referenced the meeting that Melanie and I and a few others are going to next Thursday with Julian Kelly, the National CFO of NHS England. As part of that meeting, we want to have a conversation, at least talk about the conflicting pressures that we've got around urgent care, around elective care that we've talked about at this meeting, around mental health, and to try and deliver significant financial recovery within that very difficult context is going to be a real challenge for the system. So we're looking to have a dialogue at least about a realistic financial trajectory. Clearly, we don't know the context of any agreement you might have with Treasury about the future or what that might look like or what its expectations are, but that's absolutely part of what we want to discuss.
Okay, thank you. Any other questions or comments for John? Okay, thank you. So we're asked to note the month 5 position. Thanks, John. Next, we've got the board assurance or the governing body assurance framework. Karen.
Thank you, Chair. Members will see that the GBAF is now in a different format. A lot of work has gone into tidying this up, and we hope that it's a lot more user-friendly, both for the board and for members of the public reviewing our risks. So it's here in its new format. There are a few updates which are set out in the paper. I don't propose to go through in any detail. Hopefully you've had an opportunity to read through them. So I'm just happy to take questions. Thank you.
Okay, so any comments? Hyde?
Yeah, it's not a question, but 2 comments. I like the new format, Karen, so well done on that score. And the second one is it's good to see that continuing healthcare is also recognized in the risk register. That's it for me. Thanks.
Thank you. Rob?
Yeah, thanks. Thanks for all the work on the new format, Karen. I think it's really good. I wanted to mention that in the audit committee, we did have a discussion with John about cybersecurity risks, because internationally there's been a huge increase in cyber attacks by cyber criminals, and John's going to give that further consideration. And I did notice that we've reduced the score for primary care. I don't disagree with that, but I do think we need to keep that score under close review. Thank you.
Okay, thanks, Rob. Doris?
It's just to say it's a much better format. Thank you very much. And can we roll that out to all the other committee risk map, please, because this is actually readable. Thank you.
Thanks for that, Doris. So is it transferable to everything else that we do within the CCG?
Yes, it is. Yeah. So it's taken us a bit of time to sort the GBAF out first, but the rest of it we'll be able to work through with the teams and get that done. Yes.
And just make sure you write it into the ICS governance framework as well, please.
Yeah, we won't lose it now we've done it. Don't worry.
Okay, great. Thank you. Thanks for that. So we're asked to. What are we asked to do? To note the comments and contents. Thank you. Next we've got item 18, Melanie and Karen to give us an update on ICS transition.
Do you want to start, Melanie, or should I?
Go ahead, Karen.
So there is, again, just the short update here, just setting out where we are with our ICS transition. Just a couple of points that you will have seen in the paper, but just to highlight to you, the first stage basically of the transition programme is a submission on the 29th of October. So work is underway now to pull together all the documentation for that, and the board will have an opportunity to review that work before it's submitted, along with all of our partners. We've heard about it today in the AGM, but there's quite a lot of work obviously to do on this, but we are making good progress with our different values and the work that we are doing. So just to say we're on course for everything, still a lot to do, but would welcome any thoughts or comments. Thank you.
Okay, thank you. Anything you want to add, Melanie?
No, just to really thank Karen and her team, who are just very quietly but diligently getting on with this work. It's massive amount of change and documentation, but the experience that Karen and her team have from the CCG merger has put us in very good stead, and I'm confident in their ability to support our organisation and system, but also are regularly advising the rest of the region and indeed nationally. So thank you, Karen.
No, and can I repeat that thanks as well? I was with some colleagues over the weekend from across the country, and actually when I was listening to stories around ICS development, I was thinking, oh well, we're doing pretty well in Norfolk really, because there are some places where actually they're kind of like a year behind us. So And well done, Karen and team. Any other comments or questions around ICS development? Nope, okay, thank you for that. And item 19 is a greener NHS. And John, are you going to talk about that?
Thank you, Chair. So the paper is for information. It's to make the governing body aware of the net zero commitment and ambition that the NHS has set out, to recognise the fact that I've been identified as the board lead for this, as all organisations are meant to have a board level lead. To note the fact that we are progressing through EMT, or will be progressing through EMT at the Green Plan to understand and address our response to this as an organisation. And also we've convened a meeting of ICS exec leads looking at this agenda, also linked into a regional group which is also looking at system green leads. So just to say that we're aware of the agenda, we're setting up our own internal governance and linked into other organisations. I'll leave it there and happily take any questions.
Okay, any questions or comments? You've all gone very quiet. Okay, great, thank you. So you're receiving that. And item 20 is the disciplinary policy of the CCG to approve. So Karen, do you want to just talk us through that?
Yes. Board will remember that this was prompted by NHSEI following an independent inquiry at a trust in London. We did bring this here in July, and it was thought that we should go and have another look at this with the trade unions, which we have since done. So all the changes are now set out either in highlight or in track changes for you to see. The process that we've undergone is, as I've said, to take this through the unions. We've also taken it through our staff involvement group, who've made some comments, and earlier in the week to Remuneration Committee, who actually are recommending to the governing body today that this be approved with the changes. So as you'll see, there are a number of changes there, but hopefully it makes it more supportive and positive for staff in including those changes. So I'm happy to take any questions, but I'm asking the governing body to approve the policy. Thank you.
Okay, Mark, you have a comment or question?
Thank you, Chair. I support approval of the policy. What I really like about it is the additional work you've done to flesh out why we have the policy. It's not just about pulling people over being bad. It actually explains what the role of the policy is within the organisation and supporting staff, and especially the first few paragraphs which have been changed. They're very welcome. Thank you.
Yeah, I agree. The policy statement is much more comprehensive, isn't it? Hein?
Yeah, Mark Jeffries is not here, but he asked me to speak on his behalf. So the Remuneration Committee also endorsed approval of this policy.
Okay, thank you. So we're asked to approve the policy. Can I ask you to approve? Great, thanks very much. So we're now in the final section, which is to receive reports from the committees. So we'll go through as it is. So quality performance, Kathy?
Thank you, Chair. This is a report from the August and the September meeting. Many of the items on it have already been covered in this meeting, but I'll take it as read and see if there are any further questions, please.
Okay. Any questions or comments for quality and performance? No, okay. Finance Committee, it's a verbal report from Hein.
Yeah, my update is verbal because the meeting took place a week ago at the same time as the deadline for these papers. John has in effect covered most points. We took note of the forecasted deficit at the end of the first half of the financial year of 5.9 million, but as John said, there are offsets in the system which will help us, but it does point to some underlying financial pressures for the CCG in the longer term. And we had a close look at two of the bigger areas of overspend in prescribing and continuing healthcare. and got some more detail on the emerging action plans to tackle that, and we'll continue to focus on that. I'll leave it at that. Happy to take any questions.
Okay, thank you. Any questions for Hein? No. Okay. Primary Care Committee, Doris.
I take the report as read. I've got nothing to add. Thank you.
Okay, thank you. If there's no comments, then Audit Committee, verbal from Robert.
Yeah, thank you, Chair. Yes, our meeting was about a week ago, and I just wanted to mention 3 things very briefly. Firstly, we had comprehensive updates from the internal audit team and the anti-crime team on their programme of work. This year, those programmes are progressing well. We've also done a review of the effectiveness of the committee, and we've got some ideas which will be fed into an action plan to enhance our own way of working. And then finally, to note on the review of the pharmacy rebate scheme that we received rebates worth 2.2 million in the last financial year. We'll circulate the report as soon as it's available for information to members of the governing body. And again, I'm happy to take any questions.
Okay, so any questions for Rob from the Audit Committee? No. Okay, and then from the reports, finally from the Clinical Exec, Mark.
Thank you, Chair. I'll take the report as read, and I'm very happy to answer any questions on it. Just the governing bodies members could note that in relation to the oxygen services, that is the subject of another item, which is in part 2 of the committee at the request of the lead CCG for the service. Thank you.
Okay, great, thank you. So we're on item 26, which is questions from the public. I've been advised that we haven't had any questions sent to us prior to the meeting, but we do have some members of the public, and I've got Richard Chilver's hand up. Is that to ask a question at this section of the meeting, Richard? You might be on mute, maybe.
Can you hear me now?
Yeah, I can hear you.
Yeah, fine. Yeah. Is it? Yeah, it's okay for me to go ahead now, is it? Ask questions.
If you would. Yeah, if you just.
Yeah, I did find it very difficult to. Yeah, I did initially find it quite difficult to register for the meeting to start up, really, with the codes and everything. But I finally got in, really, to be honest. But I just want one general comment, which is obviously John Ingham referred to, is basically I don't see how an organisation as vast as the NHS can actually plan for winter pressures when it doesn't even know the resources that it's likely to have in the future. I noticed that you're not in terms of the next 6 months. I don't see how it's possible to plan an organisation like that. That's just a comment. But I have a number of questions. One question is, it may be referred to, Jo Russ may have, I think she attended the AGM, over the latest on the King's Lynn Hospital, and whether in fact there's likely to be, or whether we're waiting on the government to review its capital spend for new hospitals. That's the first question. Second one is, I noticed in August that in fact that the Norfolk and Waveney health system was put on special measures. And I just wondered what the latest update was on that, because I did read somewhere that in fact you're in phase, you're in level 4 of the health service, the sort of program, and that in fact there's some kind of time set into it. So you've got otherwise there could be an outside improvement director put in or something like that. I wonder whether on that status. And third, which is more related to jabs on the booster. I mean, I'd say I have a personal issue in the sense that my sister failed for one reason or another not to take her second jab. She lives in Cromer. It was the reason because she was told to go to North Walsham at the earliest stage. She didn't take a second jab. So what is the procedure in terms of the flu jab and the booster? Is is that okay to take a booster as if you didn't take this second jab, or second or not? That's a question on that. And thirdly, I know that Melanie May referred to it, the opening, which I wasn't able to. I did just hear about it. The whole report on Corston, the closure of Corston, and whether in fact there's a learning process in terms of whose responsibility it was. Did it come under the NHS Suffolk and Health Foundation Trust, or was the CCGs in the various areas responsible for what took place there? So those are some of the questions that I request to ask. Thank you.
Thank you, Richard, and we'll attempt to answer them as much as we can today, but obviously some of them might need more detailed work. I mean, I'm happy to have a stab at the booster one. On the vaccines, I think, but by booster, do you mean the second jab or the third jab?
The third jab, I mean, which you've only just started up a week ago, really.
Yeah, well,
would that
yeah. So the third jab for COVID will be offered to all kind of over 50s and those at increased risk. But it's being done similarly to what was done initially with the initial vaccines. And it's being given to those most high risk first, and it must be at least 6 months since people had the second jab. So currently we're giving it to those patients who are clinically extremely vulnerable, and practices and hospitals are collating that information and writing out to patients. So we're doing it by invitation currently, rather than how we did the latter stages of the second, the first and second jab, where we invited by cohort and then there were walk-ins. So it's a case of people who, if they've had their jab, they need to wait for the time being. They shouldn't sort of proactively trying to contact the organisation where they had their previous jabs.
I refer to my sister. She's in nearly 70. The reason was she felt like she's allergic to the reaction to it. So I just wonder whether, in fact, that it's what the procedure is for somebody in that situation, that who is supposed to take the second jab, didn't do it for one reason or another, and then has been maybe offered the booster at a later date with tied in with the flu jab.
Well, I mean, I think there's two issues there. One is that most of the flu jabs probably won't, to start with, be given at the same time. So there probably are separate discussions. And probably it would be best for her to discuss with the vaccinator the pros and cons, because I think it's an individual decision, and the decisions around having a booster jab for her will be similar to the discussion about having the second jab that she had. So it will be a personal decision based on kind of what advice is given and her views.
All right, thank you.
Okay, and so can I ask others to answer the other questions? There was one about King's Lynn Hospital. Melanie, do you want to have a stab at the others?
Yeah, shall I just try and tackle the rest? Richard, it's lovely to see you again. And thank you for, as ever, keeping us on our toes in the way that you did at Great Yarmouth and Waveney. It's much appreciated, your input. And in terms of the Queen Elizabeth Hospital rebuild, we strongly support, as a system, the Queen Elizabeth for pushing for it to have a new build. It will be subject to quite a complex process nationally around whether the hospital will be lucky enough to be one of the 8 new designated hospitals, and that will be a government decision that's not yet been made, but we're standing shoulder to shoulder with the hospital and other partners to try and do all we can to help them be successful. The second point was around the new regime that replaces special measures, and it's called the System Recovery Programme, and it's true we've been put into the fourth segment, really, which is the lowest segment, Richard. And this wasn't a surprise to our system, given the long-standing issues that Norfolk and Waveney have had in relation to setting strategic direction, in keeping a grip of our finances historically, and also many of the quality issues that we've had. We had in one of the papers today, we set out the four areas that we're required to focus on in order to move on and out of that fourth quartile. One of those relates to improving our performance around urgent and emergency care. The second is reducing the number of people with mental health problems waiting for over 12 hours in acute hospital emergency departments. The third is for one of our trusts to exit with CQC approval, the special measures, and then lastly to improve our finance. So those are the four tests that we've been set. We've had an improvement director working with us as part of our team since Christmas, and he's brought with him quite a lot of extra resource and help. So it's been seen as quite a positive intervention so far. And then finally, we did have a long paper on Giselle Corston Park and the needless deaths of Joanna, John and Ben King. I mentioned it in my introduction as well. In terms of the responsibility, Norfolk Suffolk Foundation Trust have absolutely nothing to do with Giselle Corston Park or indeed any of those cases. The Norfolk Safeguarding Adult Board wrote recommendations to a number of organisations who had involvement in the care, and that included NHS England with their oversight of the many CCGs, including Norfolk and Waveney, but there were at least 20 others that commissioned care from those beds. They wrote to the CQC with recommendations to them as well as a body, and they also wrote to the Department of Health and Social Care with recommendations around national policy. So many organisations were involved, and there were recommendations for significant change to all of those bodies.
Thank you very much.
Okay, thank you.
Thank you.
Great. So unless there's any other questions, I think we've come to the end of the agenda, unless there's any other business. Okay, so just a reminder that the next meeting in public is on the 23rd of November, and I think we anticipate that it will be run similarly to this meeting, unless things change dramatically. So thank you everybody for attending. I'll draw the meeting to a close, and I think we'll have a 5-minute break before we have a second meeting. Thank you.